let's go to our payer, Dr. Crittenden, who's distinguished us with his presence from the West Coast. What percentage of your population with CKD ends up developing anemia? You've got all the good data. You're the data collector here.
Right. I think that's a really good question. And I'll
Why,
mirror what
thank you.
Bob. I'll mirror what Bob says here. The prevalence of anemia increases as GFR decreases, right? So in your early stage 3, you see single-digit percents of people with anemia, so less than 5%. But by the time you get to the later stages of 3, so 3B, you see anemia kind of upwards of 7 to 10%. And then as you progress through stages 4 and 5, it continues to go up. So by the time you're stage 5, about 65–70% of our patients will have some form of anemia. However, from a population health standpoint, I think one thing that's fascinating from the data is that it seems that this anemia is undertreated. So based on utilization and claims data, it seems like only about 20 or 30% of anemic CKD patients will actually receive an ESA in a given 12-month period. This is important because, as we've all kind of alluded to here, this can be a quality of life issue, and anemia is very prevalent. And if it goes under-recognized from a health plan standpoint, it seems like these patients actually have a kind of higher healthcare utilization as their anemia progresses. And again, not to mention the quality of life issues.
But monitoring this anemia costs money. How do you structure this? What are you willing to pay for in terms of monitoring them repeatedly in terms of their anemia?
Yeah, so we tend to just stick with the typical clinical practice guidelines. So KDIGO probably is the most known guideline. And so we guide our clinician partners and nephrologists to roughly mirror those guidelines. So in stage 3 patients, most folks are getting hemoglobin checks at least once a year. And remember, we just said that stage 3 patients have a minority of anemia. But by the time they're stage 4, we're looking to hemoglobins usually about twice a year. And then by the time they're stage 5, quarterly. And then, of course, if they're on dialysis, then it's once a month. And one thing too that we always like to see in the data is that if they do have anemia, we like to see some further investigation to get to the root cause of that anemia. So are their iron stores checked? Is this bleeding? Should a colonoscopy be happening? Are they having their other substrates checked, like B12 and folate? So we want to get a good picture of kind of what the underlying cause of the anemia is. Because sometimes it's not just simply the CKD alone.
This is a very unusual conversation I'm having with a payer. You sound very proactive. And in fact, you're willing to spend healthcare dollars aggressively, it sounds like, to get to the bottom of this. Is that a judgment on your part that if we can get this and find the root cause, that eventually you're going to spend less?
Right. So we know that healthcare resource utilization has increased in people with anemia of CKD. And also, this is a clinical quality of care issue. So we know that anemia and CKD is associated with some of these things that Bob alluded to: cognitive impairment, sleep disturbances, perhaps more cardiovascular complications, and even perhaps faster progression of their CKD to ESRD. And so your direct health plan costs will be more if patients are having more quality of life issues, i.e. fatigue, they're depressed, and then these people become higher healthcare resource utilizers. So for improved patient care, clinicians should probably know that anemia, at least it seems from claims utilization data, is probably a worse predictor of predictive worse outcomes. And these are independent of the costly treatment of anemia. So we should really be focusing on kind of these evidence-based standards to keep folks' hemoglobin at least in a decent range. And this is especially true for elderly patients where they have increased risk for falls, and then of course a fall will lead to hospitalization, and that leads to increased healthcare resource utilization.
So if I hear you correctly, what you're saying is that the anemia as an independent variable actually impacts everything, and that the healthcare utilization in anemic patients is higher, and so you're going to make an aggressive effort to keep the hemoglobin normal.
Correct.
Well,
normal within limits, meaning not a normal hemoglobin. Again, we want to make sure we're staying true to our guidelines here. So normal in a CKD patient would be 10, not 8.
Yeah, that's where I was going to go. What is normal? Normal is 38, 39, 40, 41. That's not what we're looking at here. Let's talk to our clinicians. Where do you look to set a hemoglobin in somebody with chronic kidney disease? Who wants to tackle that one?
So let me start and then Dan will weigh in. So there's been a lot of change over the last several years as we've learned more about where the proper hemoglobin level should be. Um, uh, Several trials a few years back, the TREAT and ACQUIRE trial, it basically shown us that high hemoglobin levels, but particularly patients who require high erythropoietin doses to reach those hemoglobins had higher cardiovascular outcomes. So a lot has changed. Prior to those trials, most nephrology practices were giving iron infusions as needed and erythropoietin injections as needed, and a much higher percent of CKD patients were having their anemia treated. It was convenient, it was done at a single visit. But since the trial suggested poorer cardiovascular outcomes, there's a black box warning so that now nephrologists basically will treat anemia to avoid transfusion. And to Stanley's point, not let the hemoglobin drop below 10. That then has shifted the therapies for anemia from the nephrologist office to a second site, typically an infusion center, maybe an oncologist office. And the problem with that is, one, there's a disconnect from nephrology, but more importantly, the patients now have an additional burden to manage their hemoglobin, particularly in Detroit, where many of our patients have to take buses to get to their office visits. It's almost impossible. So again, to Stanley's point, the number of patients treated with CKD anemia has plummeted. And Dan, I know you have your own situation in St. Louis.
Yeah, there's been a big shift. So prior to 2006 and certainly 2009, nephrologists generally started treating anemia when the hemoglobins were in the 10s and certainly in the 9s. And the treatment was overwhelmingly to give them epoetin or Aranesp or Procrit. And then secondarily, they might or might not get IV iron. They frequently would get oral iron. With the publication of some major trials showing that these increase the risk of cardiovascular events, all that's gone away. So there's a great hesitancy to treat. The average nephrologist won't even reach for Aranesp or Procrit unless the hemoglobin's persistently in the low 9s and sometimes in the 8s. And then we don't usually treat them to much above 10. And frequently we kind of wave our hand and say it's good enough when they hit the mid 9s. So there's been this big pullback from using those at all, a little increase in IV iron, but not as much as really the data indicates should have happened.
I mean, that's where I was going with this. We know the cardiovascular data is getting stronger. People with higher iron stores have increased cardiovascular risk. So it's kind of a moving target at this point. Things are changing.
Well, we do actually have data in heart failure patients, and half of those have CKD. And giving IV iron to these patients actually makes their heart failure better. They're far less likely to be admitted, and their quality of life gets better. But if they're anemic, that gets better too. So they're all tied together.